So we are live now, and I'm going to start with the session.
Yeah, sure.
Good afternoon, all. I am Arpita from the IGCP group. Welcome to today's insightful session in our Expert Clinical series. It's my pleasure to introduce our distinguished speaker for today, Dr. Anjul Dayal, a highly respected senior consultant pediatrician and pediatric intensivist at Ankura Hospital, Hyderabad. Sir holds an MBBS and DNB in pediatric and has pursued a fellowship in pediatric critical care, which is a FISCCM. With extensive experience in managing complex pediatric cases, is known for his clinical acumen and evidence-based approach to pediatric care. The topic that Sir is going to cover today is clinical curveballs, a typical presentation of severe pneumonia, a case-based analysis. Through this session, Sir will take us through real-life cases where severe pneumonia presented with unusual signs, challenging standard diagnostic thinking. So, with this very brief introduction of Sir and this session, I will now request him to please start with the topic for today. Over to you, Sir.
Thank you, Arpita. And I thank Maker Kaupal for giving me this opportunity to talk to you. So today I'll be talking to you about a complex case that we saw recently. Um, One of the things which is always there is that a severe pneumonia can present in any form. It can present just as a respiratory disorder. It can present as a multi-system disorder. It can present as the bad pneumonia along with the multi-organ dysfunctions. So they can be varied presentations. This child, when it came to us, I'll be talking to you. Initially, it looked like a dengue, and then subsequently had pneumonia and multi-organ dysfunction where we had to struggle a lot. So let's start with the case and then I'll discuss as we go forward. So this was a 14-year-old child who was admitted in another hospital before the child came to us with a fever which was there for 2 days, 2 days prior to the admission to that hospital, and that fever was there for 5 days. So at the fifth day of the fever, the child was admitted in that referral hospital. Along with the fever, the child had a pain abdomen and vomiting, and had a generalized swelling over the body. There was a decreased urine output. So since the place from where the child was referred, there was a lot of rains and the monsoon had started in that part of the place, and a lot of dengue cases were coming. So they thought it is a dengue. They did a blood test also where the platelet count was little on a lower side, so they thought it's a dengue, and then they referred the child to us for the further management to our hospital at Ankura. Now when this child reached to our hospital, now this is a 14-year-old child who was little drowsy. Now a child with a dengue usually do not develop the drowsiness, so there has to be something which was going wrong whenever we see a child with a dengue. So this child was drowsy, but more importantly he was tachypneic. He was breathing fast. His respiratory rate was 40 to 50 per minute, which was little high for a child of 14 years of age. There was a subcostal and intercostal retractions. The child was maintaining the saturations of around 94%, but he was on a non-rebreathing mask when the child was brought to our hospital. There was a bilateral decreased air entry, and there was a bilateral wheeze as well. So this child presented with these respiratory findings over there. Along with that, the child was in shock. His peripheral pulses were weak. His heart rate was high. He was having a 140 of heart rate. The capillary refill time was around 4 to 5 seconds. The blood pressure, this is a 14-year-old child, was 96 by 80. And according to the history given by the mother, the child has not passed urine for past 3 hours before the child came to us. So this child was definitely having a respiratory distress, almost going to the respiratory failure. uh, uh, Shock. The child was shocky. There was a CNS involvement. The child was drowsy. Although the abdomen was soft and there was no hepatosplenomegaly and there was no rashes over the body when we saw the child there. So, to summarize, this was a child who was drowsy with a respiratory distress, a compensated shock. Now, this shock has a very narrow pulse pressure. If you see, the blood pressure was diastolic, systolic, or not very far off, and the peripheries were cold there. And probably he had a renal involvement as well, because the child has not passed urine for 3 hours. It can still be because of the shock, it can be a pre renal, but a renal involvement could be also a possibility over there. So what we did to this child, we started the child, or gave a fluid bolus to him, normal saline of 10 ml per kilo. And Also, since the child was on NRM and he was still tachypneic, and if you see the x-ray, I have posted it over here. So this child had a bilateral hyperinflation also. There was a few crepes and there was a wheeze. So we started the child on high flow nasal cannula. So this will actually will open up the alveoli better, they recruit the alveoli. In case there's a bronchospasm also, it relieves the bronchospasm, ease off the work of breathing when the child is in ER, especially with the shock. This will actually help a lot. So we started the child in ER on HFANC. Also, since the peripheries were cold and the child's blood pressure was borderline low, we started the child on an epinephrine infusion as well, a low dose epinephrine infusion. We have sent few of the investigations, CBC, that is complete blood count, renal function test, liver function test, coagulation profile, LFTs, PTA, PTT. Then the blood was drawn for the culture. We did the blood sugar also for the child. The blood sugar was around 94 for this child, and we draw the blood for ABG. I'll be showing to you some subsequent slide. And when the child was brought to us, apart from this thing, they have done the investigations over there, which had showed the hemoglobin was 12.9, hematocrit of 38, total count was 1680, the platelet count was normal around 3 lakhs, and CRP was 69. So the questions at the time that we had is, shall we go ahead and give more fluid bolus to this child, or do we go ahead and intubate this child as well? Because the child was very drowsy, he was just responding to the pain. Otherwise the child was very drowsy over there, although the pupils were bilaterally equal and reacting to light. So the things which will help when these type of things come up is to do few of the investigations, and few of the bedside investigations, especially your POCUS, that is your ultrasound, will really help a lot. So we did this ultrasound. If you look at this ultrasound, we did looked at the lung ultrasound, which was showing the lot of B lines over there. We did an echo also for the child, which was showing the contractility was normal. And the third one over here, when we did that showed sorry we were looking at the IVC. So the IVC was not looking very taut. I mean, it was compressible. So we knew that we can give a little bit more fluid to the child, but giving too much of fluid is going to cause a problem, because already the lung ultrasound what we have done is was showing an extra B lines over there. So giving fluid is going to leak more into the lungs and is going to cause a problem over there. So we thought we should go ahead and intubate this child, because he was very tachypnic and drowsy. So it is going to take care both of the airway control, as well as the breathing part of it. Plus, even the shock will improve whenever you are trying to intubate the child in shock, because then it decreases the transthoracic pressure, the cardiac output improves. So that's going to help the child, and also the oxygenation parameters will improve. But what happened is, at this time when we were just trying to intubate the child threw an episode of seizures. Now it was a sudden thing which came up. So we gave levetiracetam as a loading dose over there. We intubated the child with 6.5 cuff tube. We were then thinking, what can be the probable reason for the seizures at this point of time? It can be hypoxia, it can be a CNS involvement because of the sepsis or infection, it can be a bleed, in the brain, it can be a stroke. So there can be a multiple reasons. So we thought we'll go ahead and do the rest of the things later, but we'll stabilize the child right now. So we intubated the child, and then subsequently we shifted this child to PICU. In PICU we put a right side IJV. If you see the x-ray over here, this is the IJV, the I mean the central line over there. We have put on a right side radial arterial line as well. We gave the platelets that we what we got over here was only 30,000. So we gave FFP cover before we put the central lines. We started the child on ventilator, and if you look at this X-ray and compare it to the X-ray, the previous one when the child came with that X-ray, there is an extensive bilateral infiltrates over here, and we did the ABG there. If you look at this ABG, it shows the pH of 7.2, PCO2 of 41. But look at the PO2. This is 68. Now, this child, we have started him on a ventilator where we were giving him a 100% FiO2. So, with a 100% FiO2, if your PO2 is only 68, you're looking at the PF ratio, which is 68, and it is very low. This probably tells us the child was going into a severe ARDS like picture. Thankfully, the bicarb was normal. The glucose, as told you, was around 94, 96 there. Lactate was little on the higher side. The child's saturation was maintaining around 90%. And now this is the child who is on a ventilator with 100% FiO2. If you look at the hemodynamics, the child was still tachycardic. The CFT was prolonged. He was on epinephrine, and we also added on norepi for this child, thinking about the sepsis. And he had an accumulative fluid balance of around 4 liters, and urine output in last 3 hours was only around 30 ml. We catheterized the child and we got only 30 ml out of from him. Now, so the problem as of now was a persistent hypoxemia. If you look at PO2, which is 68, and when you look at the SPO2, it is only 90%, and this child is on 100% of FiO2. So, how do we manage this persistent hypoxemia? So, the things that we can do on a ventilator is the PEEP titration. We titrate the PEEP, we increase the PEEP, go to to a level where the child's recruitment of the lungs, that the alveoli will open up, and this is going to actually help to improve the oxygenation status in the child. So we did the PEEP titration over here. There are various methods of doing the PEEP titration. It's given there in the tables if you look at it. So it can be an incremental PEEP where we keep on increasing the PEP, which is your positive end expiratory pressure. Usually we start with 7 or so, and then we go up to 8 to 9 to 10, 11, 14, 15. We keep on going up till we get a good recruitment. So every time that you increase your PEEP, you look at your lung compliance, you look at your PV loop, you look at the graphics in the ventilator. So usually the graphics will be very low. The PV loop will be actually very near to the x-axis, and then as you keep on giving the PEEP, increasing the PEEP, the lungs will keep on increasing. The compliance of the lung will improve. This PV loop, which is very low, will start coming a little slowly up. So till that happens, you keep on increasing, keep on looking at your hemodynamics as well. There will a stage will come when you increase your PEEP and the PV loop doesn't go any further up, and your hemodynamics might get compromised, your blood pressure will start coming down. Then you know you are over distending the lung. So then you stop increasing your PEEP. So this is the way you do the PEEP titration, by doing an incremental PEEP. There's other way, there's a decremental PEEP where you suddenly go up on the PEEP and keep the PEEP high over there, and then slowly you will come down to the PEEP where the saturation is maintained. So either way we can do it. Usually in pediatric age group we do more of an incremental PEEP. So other way of doing the lung recruitment, one I told you, is about the PEEP, intermittent PEEP, increasing and managing there. The other one is called as a sigh breath, where you, after inspiration and expiration, there will be a sigh breath which will actually increase your plateau pressure and increase your recruitment. You can do that. Mostly done more in the adults rather than the pediatric age group. And you can do a sustained high pressure inflation where you increase the PEEP to 30 to 50 and hold it there for 20 to 30 seconds, and then bring it down to maybe 10 15, where you were keeping your optimal PEEP over there. So this sustained high pressure inflation suddenly opens up the lung. All the alveoli which are closed will suddenly open up, and this will actually help to improve your hypoxemia. So this is what we were doing at the bedside for this child to improve his oxygenation. And by the time we got our blood test reports, so the hemoglobin was around 15 over here. The platelet count was around 25,000, which was pretty low. Prothrombin time was 1.8. The more important thing was SGOT and SGPT, both were very high. They were 55, 5,540 and 4,890. The CRP was 18, the procal was 20. So definitely there was some element of infection which is going on in this child. There was an element of the liver involvement, probably the inflammatory process, either because of the dengue or the infection or sepsis. So what happened at this point of time, by the time we were titrating the PEEP and trying to bring his blood pressure and the oxygenation status back to normal, the child started having a bleeding. He started having the bleeding from the nose, from the mouth, the site where we have put the central line for the child. So all these sites started having a bit of bleed over there. Although his blood pressure was maintained, his peripheries were still cold. His the intra-invasive intra-arterial blood pressure was around 94 by 70 with a mean of 88 over there. So we start thinking what can be the reason and how do we manage the bleed. So if there's a bleed which is coming from the nose, we can always do a nasal packing. We can put a pressure dressing on the central line to decrease the ooze coming out from there. If the child is having a low platelet count, like how the child was having over there, as such platelet doesn't have a number in which we transfuse. Only if there's an active bleed or you are doing any major procedures, either in dengue or otherwise, then only we give the platelet. But here, since the child was having a bleed, we gave him platelet transfusion. We gave him FFP, and vitamin K and transaminic acid also we did. The reason for the bleed, we were thinking either it can be because of the prolonged shock which was causing hypoxia and acidosis, can be thrombocytopenia, or a coagulopathy which can be sepsis induced over there. So once we have given the blood products, the bleed had stopped there. Now at 6 hours from the time the child has come to PICU, here now we were able to stabilize his blood pressure. We were able to overcome bit of hypoxia, although we were still struggling. We were on the higher settings at the ventilator. uh, if you look at the ventilatory requirements, they were going up. The child was on PRVC mode. We kept the rate of around 28 with a tidal volume of 210. The PEEP was around 8. The ABG, if you look at it, is still having an acidosis. The pH was 7.18. The PCO2 was 62, which is a little on a higher side, but we were accepting the permissive hypercapnia as long as the blood pressure is being maintained and the pH is okay. We were not trying to go up on the tidal volume because this is going to cause a problem with the injury to the lungs. So we are not trying to do that. PO2 has improved a little bit, but it was 78 coming up from 68. The bicarb was okay. The saturations were around 92%. So we were trying to accept this permissive hypercapnia with the not going too high on the ventilatory pressures. The only thing is, worry was our P plateau. If you look at it, that is one of the pressure points which tells us how much pressure we are generating on the lungs, and probably one of the signs to tell in case if there's a persistent high plateau pressure that can cause injury to the lungs. So this was on a higher side. This was around 28. So that is what the highest number that we try to maintain, around 26, 28. We don't want to go more than that. So our worry was with the ventilator, we were putting the child on the risk of developing more of a ventilatory induced lung injury, VILI, because the plateau pressure was high. The peripheries was still cold. The child was on adrenaline and noradrenaline. He has got his blood products, but our other problem was that the urine output was getting low, and the accumulative fluid balance was going to almost 6 liters now. The child was hardly passing any urine over there, and the x-ray was getting worsened. So now this worsened x-ray can be because of the two reasons. One, it can be the underlying disease condition which was getting bad. There can be associated heart induced pulmonary edema. There can be a non cardiogenic pulmonary edema, which is your ARDS, or it can be a fluid overload as well. So so these were the reasons: the fluid overload, generalized capillary leak, ARDS. There can be an associated cardiac involvement. So what do? We thought, since the child was not passing enough urine and there was a fluid overload coming up, we thought that starting the RRT, which is your renal replacement therapy, will be helpful in this child. We will try to do a little bit more of recruitment maneuver. We look in case if we can give a trial of diuretics over there, but diuretics were not working. We tried that out. Recruitment maneuver was done, and we set the P from 8 to 11 now, and he was doing better. We put this left side femoral side, the dialysis catheter, again under the ultrasound with the FFP and platelet support. We called the pediatric nephrologist because we wanted to start the CRRT. So this is a patient here where we started on CRRT. The child was, you can see this, quite bloated over there. So what happened, once we started on CRRT, we were able to get something around 1 liter of ultrafiltrate. The urine output improved a little bit, but it was still very low. The hemodynamics stabilized a little bit. Our ventilatory settings, plateau pressure, if you look at over here, was still sitting at 28. PO2 was still sitting at 60. So yeah, there was a permissive hypercapnia, a permissive hypoxia, but then a plateau pressures were high. So in case if this PO2 of 60 and PCO2 of 61 with a saturation of 90% is there, with a plateau pressure of say 25 or 24, I would have been happy. But since the plateau pressure was high, then we knew that we are actually not helping the lungs to expand a little bit more. So the lungs were bad, and what next we can do? So if you look at the algorithm of the ARDS, which will I come to the next subsequent slide, it tells you what all you can do over there. By the time we had our labs, and if you look at the labs from the admission time to 12 hours and 24 hours, the platelet count didn't change much, but SGOT was and PT were coming down. Initially they were in 5,000s, they came down to around 2,000 and odd. Electrolytes were we maintained. CRP was high from 18, it went up to 100. CPK and pro BNP was also a little on the higher side. So we knew that there's some systemic inflammatory processes going on, because the ferritin, the CPK, and LDH all were going high. So this is the algorithm I was talking to you about. When you have an ARDS, you try to do the lung protective ventilation, try to restrict the fluid, try to remove the fluid, and then look at your plateau pressure. So if your plateau pressure is around less than 30, um, maybe around 26 or so, then we are okay. You can maintain your high PEEP and all. But if it is going 30 and more than 30, then you have to either prone the child, start the child on HO4V, or go for an ECMO, and then look for the reasons why this is happening. So what we did over here, we proned the child and kept the HO4V ready. There's just in case it's not working, we kept that ready. We informed the cardiac surgeon also. We were mobilizing our ECMO also. But thankfully, what happened is, as soon as we proned this patient, the ventilation improved. The child started doing better, and we were able to come down on the plateau pressure. It came down to around 24 or so. The FiO2 from 100% started coming down to around 80, and the child was still maintaining around 94 to 95% of oxygen saturation. And since we were able to come down on the pressures, we did the bronchoalveolar lavage in this child, and bronchoalveolar lavage showed that there was a Klebsiella which was growing. It was resistant to meropenem, but it was sensitive to colistin and amikacin. So we started him on the combination according to the in ITSA guidelines. We gave the combination of meropenem plus colistin, although we know meropenem was resistant, and also added on amikacin over there. So that was helping. And also, since his ferritin and CPK were persistently very high, we also gave IVIG, intravenous immunoglobulin, to the patient. And with that, the child started improving. By day 6, he started passing urine, and we were able to stop the CRRT on day 6 over there. The ventilatory requirement came down further, and we were on the PEEP of around 6, with a tidal volume of 200, and still the lung expansion was good. We did a repeated a lung ultrasound, which is a very good modality bedside to find out about the status, and that showed that the child was doing better. The saturations were touching around 96 or so. Hemodynamics has improved. We stopped on NORAD, and then subsequently stopped the adrenaline also. 8 day of PICU stay, we were able to extubate this patient, and this patient was doing fine with that. So the learning point in this atypical presentation of pneumonia was, one was a very rapid progress. So initially the child was showing as he is developing a dengue, and the dengue test was negative, but then he developed the lung involvement. Probably it came little later. Now retrospectively thinking, probably the child had some viral infection which caused the low platelet count, and probably later on developed a lung infection. It can be an hospital acquired infection, or it can be from the community acquired as well. And this pneumonia very quickly, rapidly progressed to ARDS within a matter of 2 days, when the child started becoming tachypneic, and then developed into a multi-organ dysfunction. Now, here the ventilatory optimization for getting an adequate ventilation and oxygenation is very important. You try to do too much, give too much of pressures, you increase your plateau pressures, you might still get a good oxygenation status over there, but you will cause so much of injury to the lungs, which is going to cause the child not to improve later. You will not be able to bring him out of the ventilator, or he's going to deteriorate in next 12 hours or so. So that is very important. And knowing the goals, we were accepting the permissive hypoxia and hypercapnia, that is little lower PO2 and little higher PCO2. As far as your pH is maintained, your plateau pressure is okay. We had to intervene over here because the plateau pressure was going high. Otherwise, we would have accepted this. Then fluid removal, I think, was a game changer over here. That really helped. When we started the child on CRRT, we can see the lungs clearing off, all the fluid getting drained off. The kidneys started working better. Probably the when we were doing the CRRTs, were removing the cytokines as well. So his heart rate and your inflammatory process, everything started coming down. Although IVIG also helped over there, and then giving an appropriate antibiotics. I think doing a bronchoalveolar lavage where we were able to get Klebsiella, which was showing that it is resistant to meropenem, and then we were started on colistin and added on amikacin. That really helped over here. So the important thing about the atypical pneumonia presentation is that you don't have to only have to look at the lungs. You probably will have to look at the multiple aspects of the management, the multi-organ management, especially your heart, your kidneys, your lungs. Also the part of your nutrition. We started early nutrition therapy, and also there was a coagulability over here. The child was bleeding. Probably this was again sepsis induced or hypoxia induced coagulability. coagulopathy, and that was managed with the appropriate blood products. So those are the things which will really help over here whenever we are seeing a child with an atypical pneumonia presentation, which is just not pneumonia, it is affecting the all the organs of the body. But we were happy that we were able to the child survived, and we were able to discharge the child into the normal neurological status, the normal respiratory status, the normal cardiac and renal status, and the child was doing absolutely fine. Walked back to home on 16th day of admission. So this is what I thought I'll be talking to you about, and I'll be happy to take any questions regarding this atypical pneumonia. So thank you very much, and over to you.
Yes, sir. Thank you, sir. Thank you so much for this very insightful presentation. And let us see what are the questions that we have received. And I would request all the doctors who are with us kindly put your questions in the chat box so that I can read them out, sir. So the first question is, in your experience, what are some early clinical signs that help differentiate atypical pneumonia from more common presentations in children?
Now, that's a very good question, because we are seeing a lot of atypical pneumonias nowadays. The one thing which tells us it can be a atypical pneumonia is the rapidity with which the child deteriorates. So, usually, pneumonia starts with a bit of cold and cough and a fever, and then slowly progresses over the period of 4 to 5 days. But the child starts having a cough today, and but next day the child becomes very breathless and having a lot of fever, then we know it's an atypical pneumonia. Second thing is an associated symptoms, like the things affecting the heart, where the child goes in shock, the child develops a bad diarrhea or a vomiting, the child developing a rashes. So anything which is coming apart from the affection of the respiratory symptom, rapidly progressing pneumonia, will always tell us that this can be an atypical pneumonia.
Right, sir. Thank you so much. I would again request doctors, if you have any queries, please put them up in the chat option. You can either put it in the MedTalks platform, or those who have joined from our YouTube, they can also put it in the chat. So, going to the next question, sir. How do you decide when to escalate care from ward management to PICU admission in cases with ambiguous respiratory symptoms?
Okay, so in case if the child requires a little higher oxygen requirement, which goes more than this normal face mask, or if the child is having a multi-organ involvement apart from the respiratory, the child is in shock, the child is having a decreased urine output, coagulability, or the child respiratory status is very bad, where the child requires an ICU admission for either putting the child on high flow nasal cannula, on non invasive ventilation, or the ventilatory support itself, then this child goes into the PICU. The other important aspect is the neurological status. So, in case if the child is drowsy, the GCS is low, the child is having seizures, then these children should always go to the PICU rather than the wards.
Yes, sir. There is one question from Dr. Sonia. She wants to know, can you elaborate on the role of advanced imaging or biomarkers in diagnosing atypical or severe pneumonia cases?
Um, okay, advanced imaging. I won't say that advanced imaging, but I think a bedside imaging now has become a buzzword. So having a ultrasound, a bedside ultrasound, where you can put it on the lungs and you can look at the lungs, you can look at the B lines, you can see the fluid which is getting collected, you can look at the shred sign, which is a sign which tells us that there is an underlying consolidation. So you can have a real time images, and you can do it multiple times to know how your child is progressing. So probably, and POCUS, which is your point of care ultrasound at bedside, has changed the where we are looking at the lungs, and probably the ultrasound has become the new stethoscope for the patient. So I think when you talk about the imaging, ultrasound is what we do nowadays very often, and we have got so used to doing it that it has become one of the point of care imaging thing. Biomarkers, I think there's no specific biomarkers as such for atypical pneumonia, but nowadays we are getting this biofire test where we can take a swab from the throat or the bile sample, and we send it for the biofire, and within 3 to 4 hours we will be able to get reports about what is a probable organism over there. So that is helping us a lot. So I think biofire, either through the throat swab, et secretions, or bronchoalveolar lavage, and doing your bedside ultrasound are the important gametes in treatment of pneumonia.
Right, sir. Thank you so much, and thanks to Dr. Sonia for your question. If you have further queries, please put them up. Moving on to next question is from Dr. Ravi Shankar, sir. He wants to know what are some common diagnostic pitfalls or missteps you have observed in similar atypical presentations.
Okay. So the most common thing that we have missed out is the type of organism. Sometimes the child is so sick on a ventilator that we are not able to do the bronchoalveolar lavage. We are not able to disconnect the patient from the ventilator at all. As soon as you disconnect, the patient de-recruits and becomes hypoxic. The saturations falls down. So probably we are not able to get the sample to do the bronchoalveolar lavage, and when we don't do it, sometimes we don't get the organism properly. So the one of the things that we miss out mostly is the sampling over there. The second thing that we miss out sometimes goes very unnoticed is your fluid overload. So if you are not tracking your urine output properly and not looking at the cumulative balance, the input and output, so sometimes we think that the child is passing say 600 ml of urine in a day and we are okay with that. But what we don't realize is that probably we are giving something around 3000 to 4000 ml of fluid every day. And if he's passing only 600 to 800 ml every day, he's having a cumulative fluid positive fluid balance of around 2000 3000 ml. And this accumulates in your abdomen, puts a pressure on the chest, it accumulates in the lungs, and it makes your hypoxia even worsen. So probably that is something that we have to actively look for, and probably make sure that we are not giving too much of a fluid. There again, your bedside ultrasound to look at IVC and the contractility of the heart will help over there. So don't try to give too much of fluid, and try to remove the fluid as fast as possible, especially after 24 hours when you have done the resuscitation. Then you can always try your CRRT or SLED or IHD to remove the fluid. That's going to help. So those are the things that we usually miss out, and actively look for those things not to have a problem over there. Yeah.
Thank you so much, sir. We have one last query from Dr. Mukul Singh. And before that, I would like to announce for the last time, doctors, if you have any questions, kindly put them up, or else after this question, we are going to conclude the session. So, sir is asking, have you noticed any post-COVID changes in how severe pneumonia presents or progresses in the pediatric population?
Uh, I don't think so that COVID has made a lot of difference in pediatric, but my adult colleagues in adult ICU, they tell me that yeah, the people who are having an effect on the lungs, they keep on coming back with the pneumonia or asthma or wheezing. We don't see that much in the children, thankfully. I won't say a significant change, but what change we have seen from the time of COVID is that the inflammatory markers starts going very high. Before, we used to see a CRP going up in the bacterial infection with a WBC count going high and the CRP going high. But nowadays we are seeing a viral infections where your WBC count is normal or it is low normal, but your CRP goes very high. So there's a lot of inflammatory or systemic inflammatory response with the viral pneumonia. So that is one change that we have seen. Yes, the children who had asthma or underlying hyperreactive airway disease and they have developed a bad COVID where it affected the lungs, probably they had a little bad times during the winters with the wheezing, but otherwise I won't say too much of a changes in the COVID in the children per se.
Right, sir. Thank you so much for answering all these queries. We have received very positive feedbacks from the doctors that I'm naming: Dr. Vivek, Dr. Grover, Dr. Praval, Dr. Gaurav, Dr. Ajay, Dr. Deepak, Dr. Jagan Mohan, Dr. Goel. Sorry if I couldn't take all of the names. Thank you all for appreciating our sessions. Thank you so much. And before I wrap up with the session, I would sincerely like to thank you, sir, for your valuable time and insightful contribution to this webinar. And I'm very
Thank you.
sure all the participants who have attended this session have taken valuable takeaways that they can like apply moving forward. So thank you all for this engaging session. Thank you so much, sir, once again for your time and effort and everything. Thank you.
Thank you. Thank you.